I talked to Suzanne this morning, and I think we realized that we didn't let you know kind of what the PT students are doing, and they're going through graduation this week, so the third year students have come back from their clinicals, and embedded in their whole curriculum is they have a series, it's really a group research project, call it evidence-based practice, but throughout the entire curriculum in certain semesters they have certain class time assignments, but throughout, ultimately, the program has them work on a research project, and it's usually something that's steered on by faculty interests and stuff like that. So there's a faculty advisor, and 6 to 7 students work together with that faculty advisor, a couple faculty advisors, and do everything from submitting an IRB for approval for this project. You guys just have to
That's
do
what
that.
we're doing.
So, but ultimately in the end it culminates in one of the things that's part of their kind of their capstone experiences, which is a research presentation. And so tonight are their research presentations. And I don't know what you guys have, how far you have to go and what other things you have on your schedule, those kinds of things. But at 6 o'clock in the Mountain View room, so the big room, and outside of the Mountain View room as well, so around the cafeteria over in Flavor Hall, are all the poster presentations specific to the graduating class of 2016. So I would like to invite you guys to, if you're around and you want to hang out for a while and look at kind of what PT students were involved in, throughout their 8 semesters of their program that now culminates in this. There actually is the keynote speaker at the end of this is actually Gail Jensen from Creighton University. So she's here, she's a PT, she's here in terms of giving that keynote piece. That presentation is pretty well known in the field of physical therapy at a national level and stuff like that. So, so if you're interested, you're invited. There's no set organization of what kind of things. It's just a poster presentation. Those of you that went to your national meetings, probably somewhat similar, that there's kind of this open forum where the authors of posters are standing by them. You can ask them questions, go through that kind of process and stuff like that. And then, like I say, at the end, there's a keynote speaker. So if you are interested in hanging around this evening, we'd be welcome to have you. Okay? Now, the other thing is somewhere between last week or Monday and last week, there is actually a PowerPoint called Abdomen 2. I got no idea where it is other than it's on my C drive because I saw it this morning, but it's not anywhere here. But this is, so this is actually not going to take the entire time because I don't know what happened to the rest of the stuff. But ultimately what I want to do is get this kind of in a sense of organization and let you know what my plan is for the last couple of labs and how I want you to kind of approach the labs specific to the structures that we've talked about since the last lab exam and then the final exam, and just checking to make sure you guys are still okay to have a lecture and a lab exam on the same day, on the 9th. We're all on the same page. Okay. So anyway, so what this short presentation is about is really to get a sense of how the kind of the limits of the abdomen are defined, specific to the abdominal walls, the relationship to the diaphragm. We've talked about the diaphragm from the point of view of its function in terms of the thorax, in terms of inhalation and exhalation and that kind of thing, but to really look at it more structurally and how and what its relationship is to the trunk, as well as some of the structures we've talked about previously, and then to kind of look at the vascular supply in a little more detail when we've talked about it specific to the three primary branches coming off of the aorta. And then should you have any questions after that, we'll just figure out what to do or not to do, so. Okay? So anyway, this is an inferior view of the diaphragm. So when I did that dissection the other day, and it's kind of shredded just because of the way that thoracic cavity is kind of a mess, but ultimately what I tried to do is to come up underneath along that costal border and really the xiphoid process of the sternum, but to come up under that and kind of make a nice cut so that then we could pull that thoracic cage off and demonstrate the structures inside the thoracic cage. Now, this drawing is actually very good because it's actually kind of difficult to show this, and it's kind of gives us a better impression of how the diaphragm is setting specific to the abdominal cavity, less so from the point of view of the thoracic cavity. But when we look at this, and as a two-dimensional piece, we kind of lose perspective of this. But ultimately, our thoracic cage, at the xiphoid process, and then as we come down to these false ribs that are all interconnected by the costal cartilages that are combined going towards that, then in this two-dimensional piece looking kind of inferiorly up through the diaphragm, we see a series of three different openings. And these openings really are for the position, for allowing for the arterial and venous supply to travel through the diaphragm, as well as for the esophagus to come through then to attach to the cardiac end of the stomach. So when we look at that, when we looked at that dissection last week, we took that left lung out, and we could see the diaphragm or the aorta as it is running along the lateral side, the left lateral side of the bodies of the vertebrae. Well, the aortic hiatus is right here as that aorta comes in through in its relationship to the bodies of the vertebrae. If we come just up a little bit farther, then and go back to kind of in our mind what that looked like in the cadaver, is that esophagus is lying just right on top of, and really a little bit more towards the midline of that aorta as it travels through the thorax. And so as it comes up, then we have an esophageal hiatus. And then we go a little bit more anterior. So anterior is up to the top of the screen. And then we have another larger opening for the passage of the inferior vena cava. Okay? Now, when you look at the relationship of really kind of the contractile elements of this, then notice that the contractile elements of the diaphragm are all sort of in a circumferential way attached to the outside of that whole structure. And on the inside, there's this connective tissue, and really it's kind of a tendinous attachment. It's called the central tendon of the diaphragm. It's really kind of overlapping and interdigitating connective tissue at the ends of those particular contractile elements. So in other words, the contractility of this is not occurring right in the middle, but it's occurring in a circumference all the way around. Now the other thing to think about, which is a little bit difficult to see in this because we're now looking at it in two dimensions, is that if you look at these two kind of what appear to be openings, called gap, but this is where those most posterior inferior fibers of the diaphragm, as they're coming inferior, so coming down back here, they're now coming down, and there's this gap that allows the more proximal fibers, the kind of the beginning or the very start of the origin of psoas major, to then they wrap around that. So when you think about the idea of that, if we look at this image, so just another image of that, a little more stylized, not quite as, trying to be quite as accurate anatomically, but here you can see the diaphragm up here. Here's the central tendon. Here's the hiatus for the vena cava. Here's for the esophagus, and then back here is for the aorta. Okay. As we go inferior, what's a little bit difficult to see in this is how these muscle fibers are lying posterior to the kidney, to the suprarenal glands, and really kind of skirting around the sides of these organs and of the vessels. But now you start to see out here kind of these slips of muscles that are kind of implied here, and that's the diaphragm coming around those most proximal ends of psoas major. Okay? If we look at this in kind of this lateral view, so here's their diaphragm off of the xiphoid process, so we're not looking at the costal origin, but coming up and coming around, and here's our lung, here's our hiatus, hiati, I don't think that's really a word, but I just made it up, for the inferior vena cava, for the esophagus, and for the aorta. But the critical piece to that, and it's not drawn on here, is to how far down. So these dashed lines are kind of giving us a sense of where we are specific to the thoracic vertebrae. And again, when we look at the origin of psoas major, depending on the book you read, it's going to just begin at L1, but it can also be listed as starting all the way up to like T11 or T10. The innervation is from L1 through L4, but the origin of it is beginning somewhere up on the lateral sides of those thoracic vertebral bodies. Okay? So the diaphragm's actually overriding, or kind of running over the top of those things. Okay? If we look at it kind of in this stylized drawing, again, xiphoid process, and here's the dome. So here's our central tendon, and then here's the hiatus for the inferior vena cava. The hiatus, since we're looking at this from the right side, if we looked on the other side, or if they even had it drawn in, you should be able to see the esophagus running right here, and kind of on the other side is where you would see the aorta. So when we think about it from the point of think about how I pulled the heart out the other day. Remember that the vena cava, superior and inferior vena cava, are coming into the right atrium. And the right atrium is kind of setting kind of here, but kind of rolled behind as it goes towards the root of that right lung. And those openings through the pericardial sac are all on the right side. Specific to this, the inferior vena cava coming into the inferior part of that right atrium. Okay? When we get to that point, we've also received, or it has also received, all of the hepatic blood. Okay? So hepatic veins coming out of the liver, that's what's in abdomen 2, wherever it is. All of this coming into that now is everything from the diaphragm down. It's the venous blood supply from the lower extremities, the venous blood supply from the pelvis, the venous blood supply from abdominal organs, whether they actually that venous blood travels through that portal system into the liver or not. Okay? Now, if we look at it from this point of view, from a rostral point of view, so here we see the heart covered by the pericardium, and again, that's just the mediastinum. Okay? So we talked about the relationship of these three cavities, pleural cavities on either side, and then the mediastinum, or that midline connective tissue piece. That sits right on top of that central tendon. Okay? So think about it from the point of view as if there was contractility underneath that, as that mediastinum is attached to that central tendon or that diaphragmatic surface, then it could have a potential to influence kind of the size of that pericardial sac, which might not be the best thing if it's kind of working against what the heart's trying to do. okay? So we're at a non-contractile region here, so it has the least effect on any sort of cardiac function. Okay, anchors it for sure, but can't restrict it by changing the shape of the mediastinum. And then this is just to show the phrenic nerve coming in on either side, again, lying on the wall of the pericardium, and on one side I have that dissected out, and it's kind of flopped off to the side. So, but it's actually invested in that mediastinum. So, but here you can see kind of the doming of that again. And they're really defined as two separate domes of the diaphragm, one over the liver, which is a little bit more superiorly oriented than the one on the left side. Okay? And it's just because it's setting on top of the liver. All right? Now, hopefully this is in part review, in part new, because we haven't seen some of this. But if we look at kind of this transverse section, okay, so here's the body of the vertebrae, happens to be a lumbar vertebrae, transverse process, spinous processes, mammillary processes off the transverse process of the lumbar vertebrae. This whole region in here encases what muscles? Two groups in there. Pardon? What was that? Obliques. Well, the connective tissue is the encasement, but what are these muscles lying inside that connective tissue of the obliques? Erector spinae and transversal spinalis muscles. So there's no separation in here between those two groups of muscles. We just call them intrinsic muscles of the back. We divided them into three layers: superficial, intermediate, and deep. Superficial is only present at the thoracic or at the cervical region as splenius capitis and cervicis. The intermediate layer is erector spinae that runs the entire length. And then the transversal spinalis muscles are those that run the entire length but are much more segmentally organized. And that's semispinalis, multifidus, and rotators. When we're down here at the lumbar region, we're really looking at the transversal spinalis muscles. The most developed in that region are the multifidus muscles. Okay? But, so to go back to Maryland, here are abdominal muscles, our oblique muscles. External oblique, internal oblique, transverse abdominis. And remember, they each have, on either side of them, on the superficial side and the deep side, they have an epimysium. And that epimysium, as it comes towards this posterior lateral region, all 6 of those connective tissue layers fuse. Once they fuse, they then start to separate again, not as individual 6 layers, but as combined, to where we now have a series of 3 different layers of this thoracolumbar or thoracodorsal fascia. We have this posterior part, which is the part that you saw overlying that common broad attachment of erector spinae muscles, and latissimus dorsi is attached to that in part. And then we kind of felt our way through to feel the intermediate layer of that coming in and attaching to the transverse processes of the lumbar vertebrae. So between the posterior and the middle layers of thoracolumbar fascia, it's all called thoracolumbar fascia or thoracodorsal. Between the posterior and the middle are those intrinsic muscles of the back. And then we cut through this middle layer, and underneath that is quadratus lumborum. Okay, so attached off the iliac crest up to the transverse processes of the lumbar vertebrae and to the inferior part of rib 1. And we talked about how that muscle can be used, one, in just sort of its normal way of lateral flexion, but when we have weakened hip muscles or gluteal muscles, we can use that muscle to contract, to pull the pelvis up from on top in sort of that Trendelenburg or that lurching gait. And then there's the smallest and thinnest layer of thoracolumbar fascia lying in front of it. And that comes all the way over and kind of separates quadratus lumborum from this anterior muscle on the posterior abdominal wall, which is psoas major. Okay? And hopefully this afternoon we'll be able to kind of reflect. It's easiest to reflect it on the left side because the liver doesn't get in the way, but reflect the intestines off the left side, small intestine and the colon, and then we can look up under there and see psoas major and its relationship to iliacus, the iliac crest, as well as to quadratus lumborum. Okay? But that's kind of what we had talked about prior to this. And now we have psoas major. So when you look at how the diaphragm comes in, the diaphragm actually in that previous picture has gaps that kind of let psoas major stick through there, and then that connective tissue of the diaphragm now starts to attach to kind of this fascia that's really retroperitoneal and retrorenal that lies behind the kidney. So if we go back up to this picture, here's the kidney, here's psoas major coming off underneath, and here's that diaphragm, the tendons of that diaphragm, the connective tissue coming down, and there's a gap that kind of allows it to sweep around this side and leave space for the upper parts of psoas major to push through there. Okay? So that's kind of how we want to look at this from the posterior side, is define this as that posterior abdominal wall. Okay, we have our anterior abdominal wall. So here are the three layers. Remember, we walked them around to the front side and saw the epimysial layers of those do something similar on the front side. In other words, come together and fuse as a common attachment, as on the anterior side, come around and kind of encapsulate or encircle rectus abdominis as the rectus sheath, and then attach on the middle tube as linea alba. Okay, so here we have this entire abdominal structure, all the viscera, encircled by really more of a muscular layer than any sort of bony protection. Okay? This guy. So, now again, this is pretty stylized, so we don't really see the fascia and everything, and the thing we've talked about so far is as the aorta comes through the diaphragm, then immediately there are two branches. There's the celiac trunk that has three primary branches, arterial branches. It has more than that, but three of them, which are the splenic artery, the hepatic artery, and the left gastrointestinal artery. Okay? So three primary branches. We'll probably not worry all that much about the left gastric, but we will the splenic and the hepatic. Try to anyway. And then just inferior to that is the superior mesenteric artery, and here they're showing it crossing the renal vein to the left side. Again, you look at kind of this position and think about those the openings in the diaphragm in the central tendon, and that inferior vena cava is really off to that right side because it's ultimately going to the right side of the heart, okay? As opposed to the aorta being somewhat midline and the esophagus more anterior to that. If we go down to this image, then they have these color-coded, which makes it confusing to me, but they're just defining them as do they come off the unpaired from the anterior part of the aorta versus paired off the lateral side or paired off the posterior side. Just so you know, we're not going to worry about the posterior vessels. They're really segmental vessels that really kind of like intercostal vessels would be in the thoracic part. They do have a piece. They are part of that arterial supply that travels kind of in the between the layers of the abdominal muscles, but we're not going to trace them by any means. Okay, but here's the aorta again coming through that aortic hiatus of the diaphragm, and just as it does so, we have the celiac trunk and the superior mesenteric artery. Celiac trunk again is just liver and spleen and part of the stomach. Superior mesenteric artery is the rest of the guts, the rest of the small intestine, and 2/3 of the large intestine. So it's getting the ascending colon and the transverse colon. And then then there's quite a gap to get down to the level of L2 or 3 as the aorta is setting on it. And now we have the inferior mesenteric artery branching off there. Again, an unpaired artery. Okay, so 3 unpaired arteries coming off that anterior surface. Inferior mesenteric artery then is the one that's going to do the descending colon, sigmoid colon, and start some of the pelvic viscera. Okay? Now, the piece we haven't talked about much, other than we started down here, if we drew a line across here from ASIS to the pubic tubercle, is where we would have the inguinal ligament, and from there down we followed the femoral artery and its branches into deep femoral artery and then bifurcations down in the leg to posterior tibial, anterior tibial artery. Okay? That's just that part of it. So the end bifurcation of the aorta into common iliac vessels occurs kind of at the L4, L5 level, and then the common iliac, as it travels through the false pelvis, ultimately branches into an external and an internal iliac artery. Okay? Internal iliac artery, again, all we've seen so far, talked about so far, are the end products of that we see as part of the gluteal vasculature, which is the superior and inferior gluteal vessels that are running with the superior and inferior gluteal nerves. And that's really all we're going to go for. Okay? And again, the remainder of this as the bifurcation ultimately becomes the femoral artery. Okay? Now, if we go back up, so those are the 3 anterior unpaired pieces to this. Then there are a series of lateral paired pieces, and we're not going to really worry about suprarenal pieces of that, but certainly look at the renal arteries as they're supplying the kidneys. And then these 2 small paired branches to either side as the gonadal arteries. Now the gonadal arteries, either in our instances, are all going to be testicular arteries because we only have males, but they can be ovarian arteries as well. They're also kind of small, and they're also somewhat variable. When we look at it from the venous drainage side of that, specific to gonadal veins, if you look on the right side, the right gonadal vein comes into the vena cava, but the left gonadal vein actually comes into the left renal vein instead of coming in here. Now, over here we go back to that same picture. Here are the gonadal arteries coming off. These things are variable, and they may parallel these veins, so that we'll only have an unpaired testicular artery coming off on the right side, and this left testicular artery may not come off here, but come off of the left renal artery. Okay? The other side of that is they're so tiny in the dissection, a lot of times we don't even see them because they get torn off pretty easily. So we won't worry that much about them, but just so you know that kind of that variation. The other piece to this is now we look at sort of the paired venous drainage of this outside of the hepatic portal system. In other words, all of this, specific to all of this drainage, is musculoskeletal. Okay? So iliac veins forming the inferior vena cava, renal veins coming into it, and only at this point do we get the hepatic veins, which are the end product of venous blood from the intestines going into portal circulation, going through the liver, and ultimately coming out through that, having gone through 2 capillary beds to now become the hepatic venous blood. And at this point they join the vena cava before it goes through the diaphragm, usually. Sometimes there are instances where the right hepatic vein will actually pierce through the diaphragm and join it on the other side, or at least inside that caval hiatus. But ultimately they're all joining. Again, this is that portal blood that's been filtered twice and then goes into the vena cava and then into the heart. Okay, these pieces here called azygous and hemiazygous are really sort of ways that segmental intercostal type of blood gets back into a common trunk to then go into the vena cava, as opposed to having them come back as constant segmental pieces going into the vena cava. These are relatively difficult to dissect, but again, more segmental venous blood from the abdominal wall and intercostal region than from organ systems. Okay? Now, we'll see. It may be that we have, so the one cadaver that we've taken the thoracic cage off that has the COPD, that had that coarcted aorta, in other words, it had that weakened wall so that there was a tamponade or there was blood inside the pericardial sac. The fact that that's there would tell me that there, whatever the result was, or the risk factor was that gave that fellow COPD, if it was smoking is really a very big risk factor for the development of abdominal aortic aneurysms. Okay? They usually occur right just proximal to the bifurcation into the common iliac arteries. Okay? So in this instance, what you're really looking at is you're seeing an enlargement or ballooning of that wall of the aorta. Okay? And we've seen a number of them through the years. And if I can find one, because I took one out one year. If it's still around, I'll try to find it. But ultimately, surrounding the inferior mesenteric artery is this expansion of that wall. Now, I always think about smoking as it has this huge effect on the lungs. It gives us, smoking leads to lung cancer. Well, probably 50% or more of deaths from smoking have very little to do with the pulmonary side of this, but have a lot to do with the cardiac side. And the reason for that is when you look at what are the toxins that are associated with smoking, those toxins have a critical effect on that simple squamous epithelial lining of the vessels. That lining, that endothelial lining of our large vessels, is our protective mechanism and has these little things called tight junctions, and the toxins of those tight junctions start to break those tight junctions down. And what happens with that is then the toxins, it's not that ultimately leaves the vascular system, but it's the cholesterol salts. It's the high fatty lipids that leave that circulation and now start to dissect away the different lamina of those vessel walls, and it starts to weaken them. So we look at hearts that have atherosclerosis in them. That plaque formation has to do with the breakdown of those tight junctions or the protective mechanism of that endothelial layer. Cholesterol salts start to sequester outside within the walls of the vessels. Well, the same thing happens with respect to the smoking, is it breaks those things down, and even if there's no deposit in there, the fact that we've now opened that up and started to allow things to get in there and start to dissect away the different lamina of that tube, of that vessel wall, that begins to weaken it. And that's where we get an aneurysm, because ultimately this becomes a very weakened wall. And what happens is it gets larger. As it gets larger and expands, the wall gets thinner, and it stretches those endothelial attachments, which makes them even weaker, which lets more stuff go into them. So ultimately, these abdominal aortic aneurysms will expand to the point where they have the potential to burst. And a couple of years ago, we had a group of PA students that were working through the lab, and one of them had been working in a cardiovascular surgery center. And we had just so happened we had a large aneurysm, and that's the one I took out. So if I can find it, I'll pull it out. But ultimately what it amounts to is that PA told me that it takes, when they see these images of these enlarged aortas, is that they look at them and they don't do anything immediately until they see that the length of this kind of goes past 2 inches. And once it's past 2 inches, they feel that the wall of that vessel has become weakened enough that then it's the need to go in and surgically repair that. And the surgical repair of that is to go in and open this up and then put a stent in there and then sew the wall of the vessel back around it. Now the stent is really being that support for expansion of that particular vessel. Those stents can extend from here and extend down through the common iliac vessels and even all the way down into the femoral vessels, depending on where they can find viable tissue that they can suture to then close that particular opening up. Now, when we look at the size of this aorta in these cadavers, you'll realize that should this burst, there is very little time to save that person, because these are huge vessels. You saw the large diameter of that aorta in the one cadaver. I mean, it was about that big around. That's a lot of blood, and if it bursts, that's a lot of blood leaving fast. So hopefully I can find that aneurysm, and I had one that was repaired as well that I pulled out. But hopefully I can find that, or if not hopefully, I mean, at this point, you know, they've gifted their bodies. Maybe there's one in one of the cadavers. We don't know. you know, because the one that we've already opened up has that coarcted, which is really just a delamination of the wall of the aorta, that coarctation of the aorta in the thoracic cavity may have something else at other places, so, okay? Now, that's really all I had today, because I was gonna talk more about hepatic circulation and all that kind of stuff, but, because I don't know what happened to abdominal too. I'll find it, we'll go over it. So, here's what I wanna talk about. Here's my plan for the lab. So I mentioned projects. Katie said that would be fun, be great. And we can do that. I don't really know how I want to do that, if it's so. But in the end, what my plan to do for you guys for the lab exam, okay, is that only those structures that I find and then put on a list are going to be the structures on the lab exam specific to new stuff, head and neck, you know, muscles of facial expression, the muscles of the triangles, the structures in the triangles, or the floor of the triangle or whatever. You know, we open up another thoracic cavity. We can get some hearts out that have a little bit better demonstrations of the coronary artery circulation and stuff like that. So there are some pieces in there that we want to go through. But ultimately, you guys have today, and you really have one lab next week, which in the syllabus is just listed as kind of a review lab. So my thinking is that today in lab, what I want to be able to do is open up the abdomen of the one cadaver that we already have, that I've done the abdominal wall on. Did I show you guys the abdominal wall the other day? The 3 layers through the little windows? So I'll show you that, and then we'll open that up this afternoon. And I'll push everything from the left side away so that we can try to find the celiac trunk, superior mesenteric, inferior mesenteric arteries, the left renal artery and vein. We can see the pancreas, we can see the spleen. Then we can go back and kind of look at greater omentum, and then kind of the liver side of that, the gallbladder side of that at that point. And again, depending on how we want to do this going forward, if you guys want to take on a project and say, I'd like to dissect the urinary system, or I want to follow the kidney through the ureter to the bladder. It's kind of difficult, but we can do that. You know, again, so we can talk about that this afternoon in terms of how we want to do that. Certainly, if we want to do it as a project, I can come up with a way to add that as kind of a bonus to that, you know, to that lab exam that then, you know, would kind of give you an extra boost in terms of grades and stuff like that versus just me pointing and identifying kind of thing, okay? But we can have that discussion this afternoon, okay? If you guys have any questions, I really apologize. I don't know what happened to abdomen 2.
Okay.
Took a vacation, I guess. So, anything? Okay. So why don't we meet over this, since it's a little early, let's just meet over there at 1 o'clock, and then we'll kind of go from there and for however long you guys want. So, okay? And again, if you have the time and you want